Good morning. Can you hear me back there? I think that's John. John, can you hear me back there? We don't have the same style of microphone here. Welcome to the Department of Medicine Ground Rounds. Our speaker was just surprised that we had so many people here, so it was just difficult to kind of find out where the amphitheater is. I'm told that our original ACB amphitheater has been entirely gutted, which I think is a good thing. And that in the next few months we'll be able to get back in there with a beautifully refurnished room that we can have ground rounds in. Today is an interesting day. It was the birth back in 1859 of Sir Arthur Conan Doyle. And many of you may know that name. He created Sherlock Holmes, but very few of you probably know that he was also a physician. He was very interested in science, and that's why the scientific nature of the investigator. And on this day back in 2007 was the death of Rolf Luft, who was a Swedish endocrinologist who actually did a lot of work on diabetes and worked a lot on the mitochondria, and he sort of was felt to be the one who advanced this concept of mitochondrial medicine and diseases that have mitochondrial dysfunction. There's even a disease called, or termed in his name, Luft's disease, for mitochondrial disorder. So with that, I'll leave you with Eleanor Lederer, who's going to introduce our special guest.
Well, I am delighted to introduce our speaker today and my great friend and colleague, Dr. Kenneth McLeish. Ken has been at the University of Louisville since 1980. Yes, he's down there hiding his face as a division member of nephrology. He has served as interim division chief and now serves along with John Klein as a co-director of our research program. You know, this is going to be really fun to listen to all this construction while we're listening to you talk too, but there's a little editorial. So all of Ken's training pretty much was done at Indiana University. However, it's clearly a year of an immunology fellowship that he did at the Peter Ben Brigham that defined his career trajectory. He has been interested in the mechanisms of innate immunity and has very much defined the mechanisms by which neutrophils kill invading organisms. Additionally, more recently, he has translated these findings into application to clinical disease, and although he had always had an interest in glomerular disease, has within the last 5 years started a glomerular disease clinic here at the University of Louisville, which is really quite a unique resource both for the university and for the region. So last time that he talked, he gave us a lecture on an update in membranous nephropathy, and today I'm very pleased that he is going to give us an update on a very, very common disease that we see in the clinics and on the wards, focal segmental glomerular sclerosis. Ken?
Yes, I'm just going down the list of glomerular diseases. Which one haven't I given most recently? Thank you, Eleanor. Thank you for that. Eleanor? Oh, there you go. Thank you for that kind introduction. Thank you to all of you who made your way through the construction dust and the maze that to get here. I really appreciate that. As Eleanor pointed out, I've been interested in glomerular diseases since I was a wee lad. I can remember picking up a book by Robert Good on glomerulonephritis when I was an intern and thinking, wow, this immune complex stuff, that's sort of neat. That's interesting. Well, and I never grew past that. It is also exciting for me, being interested both from a research and a clinical standpoint in glomerular diseases, to see the progress that has been made over the past decade or so in defining all of the primary glomerular diseases. And I'm going to use what is being learned about focal segmental glomerular sclerosis as an example of the kind of progress that is being made across the board that is taking us from doing a biopsy, throwing drugs at patients and hoping for the best, to really developing a clearer understanding of what's going on and what we should do about it. Eleanor said this is a common disease that we see. It's a common disease that nephrologists see. Glomerular diseases are not common diseases. Primary glomerulonephritis occurs in about 20 cases per 100,000 population. Glomerulonephritis secondary to systemic disease is about 10 cases per 100,000 population. To put this in some perspective, at least what I looked up says that the incidence of colon cancer is about 60 cases per 100,000 population. The disease that I'm going to talk about today, focal sclerosis, is increasing in incidence and now represents about 25% of the cases of primary glomerulonephritis in adults, at least those that get biopsied. And it is changing also depending upon race. It is increasing faster in blacks than in whites, and now occurs incidence about twofold that in blacks compared to whites, for reasons that have yet to be fully determined. Clinically, basically it presents in one of two ways. The most common way that patients come to our attention is that they develop nephrotic range proteinuria. They have nephrotic syndrome along with that, particularly edema, that is what draws their attention to a problem. And at the time of presentation, they may or may not have abnormal renal function. The second way that they present, and the relative frequency of this subgroup is unknown because it is asymptomatic and they have subnephrotic proteinuria. And so we don't know how common that is, as it may never be recognized. Obviously, this clinical presentation doesn't distinguish focal segmental glomerulosclerosis from a host of other diseases, such as minimal change disease, membranous nephropathy, lupus membranous nephropathy, some cases of membranoproliferative. So one can't pick this disease out from among all of those with this type of clinical presentation. One of the true advances that has occurred over the past decade or so is in our understanding of what it is that prevents protein from appearing in the urine normally and what goes wrong leading to the proteinuria in these diseases. The drawing on the left is a cartoon of the glomerular capillary wall, showing that the filtration barrier is actually composed of multiple layers. Closest to the blood are the endothelial cells and their glycocalyx. Endothelial cells have little holes in them called fenestra that allow access of plasma to the basement membrane. The filtering process that we believe takes place at this level is primarily multi-protein complexes and cells. Next is the glomerular basement membrane itself. This is a network of filaments of collagen and other matrix proteins that provides a barrier to very large proteins the size of IgM, for example. And finally, there is the layer on the epithelial side that, at least at the level of the basement membrane, is composed of the foot processes, of podocytes, and most importantly, the connection between these foot processes, which is called the slit diaphragm. And it is the slit diaphragm that actually provides the final barrier through at least what we think are pores that are of the size and the charge that deflect albumin and any proteins larger than albumin. I like to throw this in because I think it's a pretty picture. It's a colorized scanning electron micrograph, but it does show something that you can't tell from just the two-dimensional, and that is there is this complex structure between adjacent podocytes where their foot processes actually interdigitate like fingers to cover the outside of the glomerular capillaries. So the real advance has come in terms of understanding what the slit diaphragm is, what its composition is, and how we think it might work both to maintain the structure of the podocyte and to filter protein. This drawing shows that there are a number of proteins that are contained in the slit diaphragm, the most important of which we think is nephrin, that there are adapter proteins that link the slit diaphragm to the actin cytoskeleton of the foot processes. The foot processes are linked or adhere to the glomerular basement membrane through integrin receptors, which are also linked to the actin cytoskeleton. And it is those linkages to actin that permit podocytes, their foot processes, to maintain themselves. Without that, you lose the structure of the podocytes. You develop what the pathologists call effacement or foot process fusion. On the right, we have a drawing of what we think the contribution of nephrin is. Nephrin is the blue from one podocyte and the pink from the adjacent podocyte. The electron microscopy suggests that they meet and bind to each other with immunoglobulin domains, and that there are open structures close to the plasma membrane that are the approximate size that would be predicted for the pores that would deflect albumin. So there's a lot of work going on what this structure does, how it's altered during proteinuria, and how that leads to effacement and loss of the filtration barrier. There are a number of experiments of nature where there is either mutation or deletion of these proteins or the adapters to the actin cytoskeleton, which then cause nephrotic syndrome, particularly congenital nephrotic syndrome, that confirm that they are important to maintaining the filtration barrier and the structure of the foot process. Well, like all of the primary glomerular diseases, what we call focal segmental glomerular sclerosis is not itself a disease. It is a histologic pattern of injury that has many causes. The term focal segmental glomerular sclerosis is what the pathologist sees under light microscopy. You have sclerosis. You have scarring of the glomerulus. It is focal, that is, some glomeruli are affected, others are normal. It is segmental, as shown in this drawing, where a portion of the affected glomerulus has a scar, the remaining portion appears normal. So this is entirely a pathologic description based on what is visualized under the microscope and tells us really nothing about cause and consequence. I hope there are no pathologists here because I'm going to say something that they might not like. So my observation of pathologists is that they are splitters and not lumpers, that they like to get down to the fine detail and try to categorize things based on that. And they have done so with focal segmental glomerulosclerosis and now have described 5 histologic variants based on the light microscopy. The NOS stands for not otherwise specified. meaning it's not any one of the other four. It is actually the classic version that I just described of the focal scarring. It probably accounts for about 70% of the cases of focal sclerosis that we see. So the other versions are the perihilar, where the area of sclerosis is actually at the vascular pole. There's a cellular variant which contains some endocapillary proliferation, infiltration of leukocytes, as well as some hyperplasia and proliferation of podocytes. There is the tip lesion, which a portion of the glomerulus extrudes into the proximal tubule and becomes sclerotic. And there is the collapsing variant, where there's hypertrophy and proliferation of podocytes that actually squeeze the glomerular capillaries down, making it look like they're collapsed. Well, so when we get a report back from the pathologist, it will tell us that one of these variants is present. And so the question that is most important then is, can we use that information, and is that valuable to us? And as with much information, the answer is yes and no. Clearly, the presence of the collapsing variant predicts a very poor prognosis, with up to 70% of those individuals developing renal failure by 2 to 3 years, while all of the other variants appear to be progress at about the same rate, where at 2 to 3 years you're talking about maybe 25 to 30% that will have a loss of renal function. Does it predict anything about treatment? It is thought that the tip lesion may be more responsive to therapy, but other than that, we have not identified that the histologic variants allow us to discriminate what treatment to give and how effective it will be. So the histologic variants are of some but minor utility. Well, how do we call all these things the same disease, focal sclerosis, the same description, but they're very different in their picture. So how is it that we can lump all of these things together to try to unify what's going on? And so the real question is the same pathophysiologic process responsible for all of these histologic variants? And so I'll tell you that the answer is yes, and now I'll tell you why we think that. This is taken from an article by Roger Wiggins' group at Michigan, where in No Mean Feat, they created transgenic rats where only podocytes express the human diphtheria toxin receptor. Rats do not normally express diphtheria toxin receptor. So what they created was rats with the ability to damage podocytes and podocytes alone. And then they took these rats and they gave them various doses of diphtheria toxin and looked at the effect on the kidney. Well, the first thing they showed over on the left is that increasing doses of diphtheria toxin resulted in increasing levels of proteinuria. So they could recapitulate that pattern of clinical presentation. And then they used different doses to create different levels of podocyte injury and looked at the histology. So A is basically a normal glomerulus, normal cellularity. At 10 to 20% podocyte loss, basically we begin to see what looks like the cellular variant. We have some proliferative changes that are occurring. At 30 to 50%, we're beginning to see the focal scarring, typical of the not otherwise specified version. And when we get up to 50 to 60%, we're seeing more advanced focal scarring and changes that are consistent with the collapsing variant. And finally, when we get a loss of 90+% of the podocytes, we're seeing global sclerosis of the glomerulus. So the hypothesis now is that focal sclerosis is one of a group of glomerular diseases that are referred to as podocytopathies, and that the primary lesion in focal sclerosis and minimal change disease results from injury to the podocyte, and that the histologic picture that we see is going to depend upon the extent of podocyte injury. Well, what can injure podocytes? Well, here's a long list of things that have been identified, conditions that lead to podocyte stretch. In some individuals will recapitulate this disease, probably due to other genetic alterations that prevent podocyte accommodation of stretch. There are a number of viruses, particularly the HIV virus, which can directly damage podocytes. Some drugs, heroin nephropathy is a podocytopathy. Pimidronate, lithium, and interferon gamma are on that list. More controversial is whether ischemia really leads to what we would call focal sclerosis. And then the vast array of hereditary lesions in the proteins that are making up the slit diaphragm, or the connection to the actin cytoskeleton in the foot process can do it. So if you take this entire list and look at how many patients it identifies, we're talking about maybe 10 or 15% of patients with focal sclerosis will have an etiology that's on that list. So we're down 85 to 90% in terms of trying to figure out what the true cause is. Work on this was really initiated by Virginia Saven and her colleagues back in the late 80s, early 90s, when they took isolated rat glomeruli, infused those glomeruli with either the plasma or sera from patients with focal sclerosis or other renal diseases, and then subsequently perfused the glomerular capillaries with an albumin-containing solution and looked at the leakage of albumin through the capillaries. And without belaboring what this experiment is, what they defined was that there was a low molecular weight substance in the sera of patients with focal sclerosis that increased permeability to albumin. So they promoted this hypothesis that there was a circulating permeability factor that caused this disease. And they looked and they looked and they looked. And it wasn't until 2011 that Reiser's group actually had identified something that they think may be the permeability factor. And this is the soluble urokinase receptor, which is called SUPAR. And the data that they published show that patients with focal sclerosis have significantly elevated some very high levels of the soluble urokinase receptor in their blood, while normals, patients with minimal change disease, membranous nephropathy, preeclampsia, do not have these elevated levels. Well, so what is the urokinase receptor and how might it be causing a change that would lead to focal sclerosis? This drawing summarizes some of the things that this receptor does. Whether this interaction with integrin receptors is mediated by binding of urokinase to the receptor or not, as you can see, is a question, but the urokinase receptor is bound to the plasma membrane by a glycosylphospholinositol linkage, GPI linkage, that allows it to move in the membrane and bind to integrins. The binding to integrins changes both the inside and outside of the cell. It enhances the affinity of integrins for their ligands, making the cell stickier, and it also results in outside-in signaling that enhances actin polymerization, so it changes the cytoskeletal structure of the cell. Finally, in terms of how it might be involved in focal sclerosis, it's well known that enzymatic cleavage of these GPI linkages is relatively common, and this could account for the release of significant amounts of the urokinase receptor into the blood. So Reiser's group tried to close the loop by looking at the effect of administration of recombinant SUPAR to urokinase receptor knockout mice to see whether it recapitulated any of the findings in focal glomerulosclerosis. They demonstrated at the highest concentration they gave, 20 micrograms, that 24 hours after a single dose, there was a significant increase in proteinuria. And using immunofluorescence microscopy of glomeruli, they showed that this soluble urokinase receptor that they were administering bound to the glomerulus. It bound in a pattern similar to proteins that were associated with podocytes, and using an antibody that identified activated integrins, they showed that binding of this soluble urokinase receptor resulted in a significant increase in integrin activation in podocytes, all consistent with a change that we saw occurring in podocytes in Wiggins' study. They then went on to create a more longer-term model where they changed skin cells so that they excreted the soluble urokinase receptor and inserted either the wild type or a urokinase receptor that had a mutation that did not bind to the integrins. And they showed that with the wild type urokinase receptor, they saw proteinuria in the mutant that did not bind integrins. They did not have proteinuria. And the wild type induced foot process fusion and sclerosis of the glomeruli, whereas the mutant did not. And so based on this study, they came up with this model for focal sclerosis. That is that they think that the soluble urokinase receptor comes from circulating neutrophils or monocytes. It is cleaved off, enters the circulation, goes to the glomerulus where it binds to the integrins linking the foot processes to the glomerular basement membrane. It increases the affinity of those integrins for the basement membrane, allowing spreading of the foot process. It disrupts the actin cytoskeleton, leading to effacement, loss of the integrity of the slit diaphragm, and proteinuria. Now, this is a neat story. And if it ended there, it'd really be a neat story. But as with most discoveries in science, the initial enthusiasm is met with pushback when data are generated. And so some of the data that bring this story into question are shown here. At the far left is a second study by Reiser's group where they looked at two large cohorts of patients with focal sclerosis to see whether they had elevated SUPAR levels. And although they were statistically significantly different, as even they point out, there was significant overlap with normal controls. On the far right is an example of one of several studies where patients with focal sclerosis didn't have elevated levels compared to other diseases or healthy controls. And in the middle is an example of one of several studies where when they looked and compared the levels in individuals with abnormal renal function in focal sclerosis versus normal renal function, it was only those that had a GFR less than 30 that had elevated levels. And indeed, investigators have recently published that the level of glomerular filtration rate has a greater influence on the level of soluble urokinase receptors than does the disease that the patient has. So the story is more complicated, and very recently, this is out in PubMed, but not in print yet, that group from France has relooked at the ability of injection of the soluble urokinase receptor in the mice to cause proteinuria and foot process effacement, and neither proteinuria nor foot process effacement was observed. Well, now the story's not looking so good. So should we abandon this? And right now the answer is no, and there are a couple of potential reasons for that. One of the reasons is that the cleavage of the urokinase receptor from the plasma membrane does not result in the release of the entire receptor. It is actually further cleaved into 3 possible fragments. This, from Reiser's publication, shows that the lower molecular weight fragment is apparently the most common, at least in focal sclerosis. So it's certainly possible that the ELISA, commercial ELISA, that every laboratory so far has used to detect the soluble urokinase receptor doesn't actually detect the fragment that is most important in causing focal sclerosis. A second possibility that Reiser's group is pursuing, and John Klein is involved in these studies, is that there are post-translational modifications to these fragments that are important in causing focal sclerosis, and those post-translational modifications have no influence on picking up the actual quantity of the circulating fragments of the urokinase receptor. Well, so let's move on and talk about treatment. The first question is, should everybody with focal sclerosis be treated? Are there subgroups that we should focus on? And the answer is there are subgroups. This shows the progression toward renal failure based on the level of protein excretion. People with focal sclerosis who have subnephrotic levels of proteinuria have a very low level of renal failure, 10 to 15% at a decade, so they are likely to do well without treatment. On the other hand, nephrotic syndrome patients have about a 60% level of end-stage renal disease at a decade, and those with very high levels, greater than 14 grams a day, all of them have renal failure by 5 to 6 years. So level of protein should determine whether we consider treatment. Are treatments available? Well, as the history of most primary glomerular diseases, we have thrown a whole bunch of immunosuppressive agents at them to see whether they work. And in most cases, they do to some degree for reasons that we still haven't figured out. So this is a compilation of a number of studies that I've combined into one table. And actually, 3 of the studies contained untreated controls, which I think is instructive because the rate of spontaneous remission in those individuals with nephrotic syndrome from focal sclerosis is very low. So identifying this group of patients means that we should proceed to treatment rather than procrastinating to see whether things will get better. Sometime in the late 80s or early 90s, it was suggested that maybe a prolonged course of corticosteroids rather than the short course that we give for minimal change disease might be effective. And this has been confirmed in 4 studies containing over 200 patients where either a complete or partial remission was obtained in over 70%. Complete remission typically defined as induction of less than 500 milligrams a day in protein excretion. Partial remission defined as at least a 50% reduction in proteinuria to less than 3 grams a day. So this will be important in a minute because this is proteinuria, and what we're really trying to prevent is renal failure. And so we'll try to tie those together in a minute. Well, 2 things happen in people on corticosteroids that develop remissions. Either you can't get them off the corticosteroids, they become steroid dependent with long-term complications from their steroids, or they have frequent relapses and get treatment over and over again with steroids, neither of which is a walk in the park. So a number of other agents have been looked at to see whether they might be beneficial. The calcineurin inhibitors, cyclosporin and tacrolimus, have been studied and induce remission in anywhere from 45 to 60% of patients. Mycophenolate mofetil, only 40%. The ACTH gel has been popular in Europe and has only recently become available in the United States. Small study, 2 small studies, only 30%. And cyclophosphamide, which is one of the treatments that we frequently use in minimal change disease, about 50% of those patients will undergo a remission. Well, taking this table as a whole, you'd say, well, you should always give steroids first. All of the rest of them are not as effective. The caveat, and indeed, if you read the expert opinion on treatment, that's what most of the expert opinions say. The caveat to that conclusion is that almost all of the studies looking at agents other than corticosteroids define their enrollment group based on failure of response to corticosteroids. And so the patients that are likely to easily have responded to any one of a number of agents were already eliminated from the study. So at least in my expert opinion, for what that's worth, I think that the calcineurin inhibitors and corticosteroids are equally effective at inducing remission. And when I talk to patients, I offer them the option of either a calcineurin inhibitor or a corticosteroid after we've talked about the side effects and length of treatment, and allow them to have input into that decision. I didn't want to do that. I have too many things here to look at. Back on track. Okay, so as I said, the question is, when we talk about remission of proteinuria, does this really change the course of the disease? And this graph shows that the answer is yes. The solid line are those patients with focal sclerosis who do not develop a remission, showing the percent renal survival, which out at a decade is somewhere around 30%. The hatched lines show complete and partial remission and the survival of kidney function, showing that, number one, those two are approximately equal, so achieving a partial remission is as good as achieving a complete remission, and that you provide a substantial survival advantage to the patient's kidneys and therefore the patient by keeping them off dialysis with treatment and attaining a remission. A new concept that has come up just recently, and I'll mention it specifically for the nephrologists and nephrology fellows that are going to have to take boards, because this is now appearing on the boards, is the effect of rituximab on this disease. In children, rituximab may induce a remission. In adults, rituximab alone is not effective. However, this recent report from Ramuzzi's group shows that there may be a beneficial effect of rituximab in terms of preventing relapses in both minimal change disease and focal sclerosis. This is the relapse rate in those patients, showing that a single dose of rituximab given after a remission induced by steroids dramatically changes the frequency of relapses and reduces the dose of steroid, total dose of steroid that is required to be given to those patients. So rituximab may have a role in those individuals that are steroid dependent or frequently relapsing in trying to keep them from getting the complications of corticosteroids. Well, so in terms of treatment, the last story that I want to tell has to do with a molecule called B71. So this is again work where Reiser was, whoops, I'm losing track of my buttons. Here we go. So this is again from Reiser's group, where they disrupted podocyte interaction with the glomerular basement membrane by essentially deleting the integrin receptor that's involved. And then they did this genetic screen to see, well, what molecules, what genes are regulated in those podocytes. And one of the genes that was regulated was the gene for this molecule called B71. They then looked at ground up podocytes and showed that the protein was actually expressed after they disrupted its interaction with the glomerular basement membrane. And that if you look at immunofluorescence of glomeruli from mice where this disruption has taken place, you see this staining that appears for B71. It's in the same pattern as proteins that appear on podocytes. And they were able to show that if you induced proteinuria in mice that had a deletion of the gene for B71, that as compared to other mice, controls and others, they did not develop proteinuria. So not only was this molecule upregulated, but its upregulation had a role in the development in proteinuria in a situation where podocytes were disrupted. Fast forward almost a decade, and this work has recently appeared in the New England Journal, where Peter Mundell and his collaborators looked at the expression of B71 in the biopsies from a number of different types of glomerular disease. And as you can see, focal sclerosis, 2 out of 3 had it, minimal change disease, pretty common, membranous nephropathy, lupus nephropathy. So it is not specific for any one disease, but damage to the podocytes in humans results in increased expression of this molecule in at least some individuals. Well, what is B71? Actually, it is well known to the immunology community because it is a co-stimulatory regulator by which antigen-presenting cells activate T regulatory cells. And because it's known to the immunology and the transplant community, they decided, well, if we block that, maybe we can prevent rejection. And so some drugs that are monoclonal antibodies to B71 had already been created. And Mundell's group went ahead and tested those in 5 patients with focal sclerosis. 5 patients with focal sclerosis. 4 of those 5 patients were actually recurrence after a transplant, and all of them responded to a single dose of one of the anti-B71 monoclonals called abatacept. These are the data from the one patient with primary glomerular or primary focal sclerosis showing the outcome where initially nephrotic, after abatacept they had a partial remission, then relapsed, and subsequently have been given serial doses of abatacept and have over approximately 1 year attained a complete remission in their proteinuria. Down at the bottom is shown the fact that it was confirmed that they did express B71 in the glomerulus. So 5 patients doesn't a trend make. However, the importance of this was commented on in an editorial in the same journal, that this really substantially changes the paradigm by which we are treating glomerular diseases, or should be treating them. Now we're going to act more like oncologists, where we look at the surface molecules or receptors on cancer cells and use what's present on those cells to guide our therapy. Now we may be at an early stage where we're going to look at what molecules are expressed on glomerular cells and be able to use that to guide more specific and hopefully less toxic therapy. Just to summarize this portion, the proposed mechanism for B7-1 or CD80 contribution to podocyte injury, the proposal is that first there is some type of glomerular injury to the podocyte. This leads to podocyte induction of B7-1 expression. This B7-1, again, interacts with integrins to prevent their activation and prevent their ability to mediate adhesion. That this loss of adhesion results in either increased migration or loss of contact of podocytes with the glomerular basement membrane, leading to proteinuria and sclerosis. Abatacept acts by interacting with the B7-1 molecule and blocking its interaction with integrins, and thereby allowing normal integrin function. So, to summarize some of the reasons why I get excited, we've learned that focal segmental glomerulosclerosis is a podocytopathy, that it is mediated by injury directly to the podocytes. Two potential causative agents, the B7-1 and SUPAR, have been identified, and a common theme for both of them is something that disrupts adhesion and actin cytoskeleton in the podocyte. Current treatment is able to induce remission and thereby reduce the risk of renal failure in 50 to 75% of patients, but this comes at a cost of a significant number of side effects. And that we are now entering an era where the enhanced understanding of the molecular mechanisms for both proteinuria and podocyte injury appear to be leading to more specific therapies that hopefully will be less toxic. I appreciate all of you coming. I appreciate your attention. I'll be happy to answer any questions.
And that was a great review, and I'm always amazed as to how diseases in one organ follow similar pathways as other organs. And I just came back from the American Thoracic Society meeting where much of the discussion was about idiopathic pulmonary fibrosis, because there was an unveiling of two drugs. There will probably be the first two drugs available to treat that disease. And I want to come to the rescue of the pathologist. And I'll get to a question in a second, but let me come to
I was going to say, are we just going to talk about your trip to San Diego?
Give me the microphone. So let me tell you a couple of things about the pathologist. So in the area of pulmonary disease, such as in the area of renal glomerulosclerosis, there was no advancement until a few pathologists actually came together and began to split how the pathology of the lung in fibrotic lung disease looked at. And if you say, that doesn't make any difference because what am I going to do with these different entities? And then somebody showed a slide similar to the one you showed about survival and showed that some of these pathologists showed bad survival and the other one showed better. And then they said, oh my God, now we can start dissociating this, splitting them, and looking which one, and that came the definition of idiopathic interstitial pneumonia. Then they were studying the epithelial cell, in this case would be more reminiscent to the podocyte. And they started looking at the integrins, and they found that these integrins, when they became activated, they actually induced TGF-beta and affected permeability and so forth. And then they started looking at genetics, and they found a bunch of these things like you are finding in genetics in your disease. They start looking at medications, and the list of medications are essentially identical to the list of medications you showed on that list. And in fact, I now serve on one of the committees looking at a rituximab trial to study pulmonary fibrosis.
Nobody should die without receiving rituximab.
And then you show the slide of looking for surrogate markers of the disease, and you were thinking about the drop in proteinuria, and we look at the drop of FVC. So you excrete protein, we excrete air. And it all seems very similar, except for one thing. One thing. The pulmonary world is now refocusing on the matrix. Because it's appeared that when you decellularize these fibrotic lungs, it turns out the matrix has been so screwed up that even if you fix the cells and what they do in the cytokines, they can't regenerate a normal organ again because the matrix is all affected. So considering that this is a sclerosing disease, tell me what is known about the matrix and integrin binding and that kind of thing.
So you got 2 grand rounds for the price of one. Well, I guess the short answer is very little. And at this point in time, I am not aware of any studies that have tried to differentiate the matrix proteins in the various sclerotic diseases that affect glomeruli, whether it be diabetes or hypertension or focal sclerosis. We're following similar trajectories. As usual, we would appear to be a couple of years behind what's going on in another specialty.
Questions?
Dr. Lederer.
Thank you. So let's talk about the proximal tubule.
It all comes down to the proximal tube. To my knowledge, they do not have cilia.
Moving on. By the way,
And it is all about the tubule. I mean, we have this continual banter about what should be looked at. Just because they haven't been identified doesn't mean they aren't there.
Yes, sir.
So I didn't go into a lot of the details on the slide of the 10 gazillion things that we think cause it. Under the hyperfiltration and podocyte stretch, that's where obesity comes. There is evidence for hyperfiltration in obese individuals. Yes. The stretch issue is believed to be what puts tension on the podocyte, and sometimes it doesn't react well. So we have these secondary causes. I didn't go into it, but treatment of secondary forms of focal sclerosis with the usual and customary agents is only about half as effective as it is in the so-called idiopathic form of focal sclerosis. So there are differences there in terms of etiology. Obesity is one of those where giving steroids is not the greatest idea anyhow, but the response rate is now 35% rather than 70%. The problem with that is that the only people right now who think they can tell us whether somebody has a primary or a secondary form are the pathologists. And they do so by saying, well, the foot process effacement is only focal rather than generalized, and that's associated more with secondary causes than primary causes. Weak linkage, and there is no gold standard by which to diagnose either of those, either a primary or secondary form. So how common it is, why we aren't seeing a ton of it because obesity is becoming epidemic. A lot of it has to do with we don't know how to identify when obesity has actually caused it, but it can.
And is diagnosis typically dependent on biopsy, or do you treat and then if it doesn't work, then you move on to biopsy?
So if you're a pediatrician, you treat and then biopsy. If you're an adult nephrologist, you biopsy. Because of the relative frequency of the diseases, minimal change disease being so common in the children, and focal sclerosis being the most common, but you can see it's only 25%. We see a lot of variation and treatments do tend to differ some, anyhow, between these various diseases.
Last comment or question?
You're in the dark, John.
So I just, since you mentioned it, I wanted to follow up just with a comment that I think the CFAR story is actually just beginning. We're kind of in the second inning. In the next month, there'll be a couple articles published, not yet online, that link CFAR to diabetic nephropathy and some of the post-translational modifications affecting diabetes linked to that story as well. And since you were kind enough to mention it, and I don't like taking credit when I don't deserve it, the laboratory here at U of L is collaborating with Dr. Rice and Dr. Sedgwick and our scientist who is doing the bulk of that work is Dr. Chan Cock, who's down there, and who's looking at not only post-translational modifications in CFAR, but also differences in the domain structure that's expressed on patients with severe disease versus those with mild disease. And then also, with help also Dr. Mike Martinez-Osi, Dr. Roger Rush, and Dr. Severos from Harvard. And we actually think we're going to have some interesting papers to come from it. So I think it's just starting to see light.
I always find it exciting when I hear ground rounds where there's a combination or a blend of clinical medicine and science, because I don't think you can advance one without the other. You certainly can't advance clinical medicine without discovery. This was a great ground round. Thank you very much, Ken.
Thank you.
Very to the point, very nicely done. Thank you. Thank you. It was scary for me to listen to the story of this, and I'm thinking, oh my God, we're doing exactly the same things. So, what